about both the science and the policy associated with this, and perhaps give you some historical perspective about how we got to where we are and how following the science and our commitment to being evidence-based has brought us to the point where we are really very confident now in what we're talking about. So going back a little bit historically, some of you may remember it was just a few days from now, a year ago, at the IAS 2017 meeting that we had a discussion publicly and with a bunch of questions about the concept of U equals U, its reality and its feasibility of being accepted. Note the date, July 24th, 2017. Approximately 2 weeks later, having been thoroughly convinced about the scientific basis for this, as was alluded to, I shocked a few people by, at the U.S. Conference on AIDS, coming out and definitively saying at that conference that I believe strongly that the scientific basis is there for being able to say U equals U. I wanted to make sure that everybody understood with no ambiguity about what I was talking about. So with a great deal of artistic skill, I made the slide on the right, which is pretty simple if you have a word processor. However, it did not stay there, because literally about a week and a half, 2 weeks later, the CDC came out and said the same thing. People who take ART daily as prescribed and achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV-negative partner. And as we know, just this month, WHO also came out with a statement that there is no evidence that individuals who've successfully achieved and maintained viral suppression through ART transmit the virus sexually to their HIV-negative partner. So now we have a whole bunch of different groups representing different aspects of the public health community coming out definitively talking about that. So since we are talking about it, since people will continue to question us, let's take a look at the scientific data so that we can come back and say what we say is thoroughly evidence-based. So there are 5 aspects that I want to quickly go through temporally from the very beginning until where we are right now, and then I'll close with some what I call additional considerations. First, let's take a look at the concept in a vacuum. No ART, no viral load, just the concept about HIV transmission, and why one would have predicted a long time ago that if you had a negative viral load, you would not be able to transmit. So the first thing is, despite the fact, and again, I don't want to belittle the extraordinary burden that we're facing with 77 million people having been infected with HIV and more than 37 million dead and 36 million people living with HIV. In fact, sexual transmission of HIV is relatively inefficient. It is. Why do we say that? Well, this is work that we did in my lab years ago, Ashley Haas and others have been doing, and that is that it is difficult for the virus in an otherwise uninflamed mucosa to actually find its target cell, and its target cell is an activated T cell. So just from stochastically alone, it's difficult for the virus to find the cell. Now, in reality, it's found it 77 million times, so don't underplay that. But in reality, it is. And if you look at the probability of infection, it is borne out. Because if you measure, and these measurements are somewhat imprecise, but not completely outlandish, that if you look at receptive anal intercourse, the risk is 138 per 10,000 exposures. It goes way down when you talk about insertive penile vaginal intercourse, where the risk is 4 per 10,000 exposures. So just take that as a background as we start talking about viral load and we start talking about ART. So let's look at things in the pre-ART area. What we were observing before we had antiretroviral drugs. This is a study from my group led by Tom Quinn. We have a group in the Rakai district of Uganda, and Tom and Ron Gray and their colleagues were following discordant couples. And they found, just by observation, that if you look at the viral load of individuals, you find a very interesting linear relationship between the higher the viral load and the greater the chance of transmitting. But they also noticed, buried in those data, that in any of their serodiscordant couples, if the viral load was less than 1,500, there were no viral transmission in 51 couples, which was the first inkling. Remember, this is March 2000, 18 years ago, the first inkling of that. Then if you look at a study from Thailand, again, very similar. They were observing heterosexual couples. Nobody was on ART now. We're going to get to ART in a second. Nobody was on ART, but they just looked at the relationship between the viral load and transmissibility. And similar to the Ugandan study, they found that if a couple in which the discordant person had less than 1,094 copies, there was no viral transmission. So the data are starting to accumulate in an era a long time ago. You switch over to maternal child transmission, the same thing. These individuals were not receiving antiretroviral drugs. This was no AZT. This was 1999, and they looked at 321 HIV-infected women, and note the graph on the lower right. Again, a direct inverse relationship between the amount of virus and the likelihood or not that they will transmit. Now, let's get to the area of ART, because it gets a little bit more definitive when you do that. Now, many of you are familiar with this slide. It's the temporal scheme and runoff from we went to no antiretroviral drugs, which is what I was talking about over the previous few minutes, to 1, 2, 3, 4, and then a lot of antiretroviral drugs. And it's an interesting story about the availability of antiretroviral drugs and the ability or not to decrease the viral load to below detectable level. So let's take a look at that. Since, fortunately or unfortunately, given my age, I was there from the first slide. And that is, back when we had no drugs, I already told you about that. But when I first started using AZT as monotherapy, what we saw is what's shown on the left-hand panel. A modest, at best, drop in viral load that was certainly not sustainable for months to less than half a year. When we graduated to 2 drugs, we saw a bit more of a drop in viral load that still was not sustainable. But the transforming event in the therapy of HIV came in 1996, and it got better and better ever since. And that was the first use of a triple combination, and one that really actually started it all was the addition of the protease inhibitors to a triple drug combination. We have much better drugs than protease inhibitors now, but that started it off. And what did that mean? That means that if a person took their drug, it would bring the viral load to below detectable level, and it would be sustainable essentially indefinitely. So you just have to pause there for a moment, because with all of the leading up to it, that was the definitive moment, and we didn't even realize it then, of U equals U. So it was happening before we even realized it was happening. Not only was it good for the individual, because as when I first started taking care of HIV-infected individuals, before it was HIV and before it was AIDS, in the summer of 1981, the patients that I took care of had a median survival of less than a year. Now, if a person takes an antiretroviral drug, in their mid-20s, we can predict that they would live an additional 50-plus years. So for the individual, it's life-transforming. But now, what about the spin-offs of that? There are 3 areas of spin-offs that I want to briefly mention to you, because it'll lead up again to what I'm getting to, and you obviously know, is the accumulation of data that says it's justifiable. Mother-to-child transmission. Now, in this study from Cooper et al. In 2002, when they looked at over 1,000 pregnant HIV-infected individuals who received any antiretroviral therapy, what they found, this isn't U equals U yet, they found what we were seeing all along, even before antiretroviral therapy, that there was an inverse relationship between the level of virus shown on the x-axis and the percent rate of perinatal transmission. The higher the virus, the greater the chance; the lower the virus, the least chance, suggesting that if there's no virus there, it's going to be 0. But we don't know that yet with this study. Then came along the real proof, namely in discordant couples. So let's go through a couple of those studies. A serodiscordant couple study in Spain showed that there was no HIV transmission when the HIV partner was receiving ART. Now, this is a study that didn't carefully measure viral load, just being on ART versus not being on ART. There was 8.6% transmission when the HIV-infected partner was not receiving ART, and there were no transmissions, even when you were not measuring viral load. Again, more and more evidence accumulating. Then there was this study here of 7 African countries, the same situation. They had 103 genetically HIV transmissions, linked transmissions. Only 1 was when the person was on ART. But I want to get back to that 1, because it's going to get to what I'm going to say in a couple of minutes. That single transmission happened when the person who was receiving ART had only been on ART less than 4 months. So there's going to be a little caveat that's going to go along with that. So there was nothing if you were on for more than 4 months, 1 out of 103 if you were on less than 4 months. Then there was a meta-analysis among a number of studies, 11 cohorts. The transmission rate from a positive partner receiving ART, if the viral load was less than 400, which is the cutoff in some countries. Sometimes it's less than 200, less than 20, less than 40, but 400 is a reasonable number. Again, 0 transmissions when the seropositive partner had a viral load of less than 400. But then there's the community correlations. What does that mean? Instead of looking at individual studies, find out when you introduce antiretroviral drugs into a community, does the community incidence go down? It's a different kind of a study than looking at individual people. And there are a couple of studies that clearly nail that down. One, around my neighborhood, just north of where I am in Baltimore, in the blue is the percent of people who are virally suppressed in the community in Baltimore, mostly around Hopkins Hospital. In the red is the incidence that is temporally superimposed upon the number of people on therapy. The same in Rwanda. As you increase the percent of people who are on antiretroviral drugs, the percent incidence of disease in that community goes down. Now comes the real knockout studies, HPTN 052 and subsequent studies. So, you know, it's interesting because people get very excited about HPTN 052, but there are 2 aspects of it. The first aspect is that when we looked at over 1,700 serodiscordant couples in 9 countries, if you compared giving the drug ARTs combination immediately when the CD4 count was between 350 to 500, or wait until it dropped to less than 250, there was a 96% reduction in HIV transmission in the group that got it immediately. Now, that doesn't really quite yet tell you that U equals U, but it strongly is suggesting it. This was so strong, and I like this. John Cohen, my friend, wrote an article in Science showing that 052 was the breakthrough of the year. Now, for those of you not involved in basic research versus clinical research, science never gives the breakthrough of the year to a clinical study. And this was a clinic, it's usually some receptor that gets cloned or something like that. But this was a clinical study that got breakthrough of the year. Now, several years later in the follow-up was when they really nailed it down. And that is now, they're looking actually at viral load. And two good things about this follow-up study that are underappreciated. One, multiple years later, 5 years later, the data stood solid. That doesn't happen often in medicine, that you do a study and then 5 years later you follow it up and the data are just as good. But they were. But importantly, now they're measuring viral load, and they found 0 linked infections in individuals who had an undetectable viral load. So of all the things I've showed you, this really is one that totally nails it down. Now we get a little complicated. Now we have the partner study, because the question is, the studies that you're doing are geared towards heterosexual couples, not exclusively heterosexual couples, but much more geared to them. What about in men who have sex with men? So take a look at the partner study. What they did is that they looked at 58,000 condomless sexual acts and found no linked HIV transmission with an HIV partner who had a suppressed viral load. But when you mine down into partner 1, they call it, because partner 2 is coming up soon, if the partner study, you find, if you look at the breakdown, there were heterosexual men, heterosexual women, and men who have sex with men. So about 2/3 or less were not in men who have sex with men. So the obvious question people asked, they certainly asked me a lot, well, are the data really strong for U equals U in gay men? Let's take a look at that. The opposite ATTRACT study, again, which is 343 serodiscordant men who have sex with men in Australia, Thailand, and Brazil. And here come the data now. 16,800 acts of condomless anal intercourse and no linked transmissions in 588 couple years. Now, if you put them together, put partners together with opposites attract, there are nearly 35,000 acts of condomless anal intercourse in gay male couples. So saying that the data are not strong for gay men is just belies what the facts are, that it is strong. 0 link transmission. Now, on July 24th, which is 2 days from now, Partners 2 study is going to come out. It's going to build on Partner 1. So Partner 1 was 340 or men who have sex with men. Partner 2 is going to enroll, has enrolled 450 HIV serodiscordant men who have sex with men in a study from 2014 to 2017. So I'm not going to anticipate their results. You're going to hear about it on the 24th, but you can kind of guess what the results are going to show. I didn't say that. So let me close with some additional considerations that I think are important, because there is always, and I've experienced it myself clearly, pushback about this concept. So let me take a couple of things into consideration for you so that when you have your discussions and you get into kind of mini debates with people, you can at least use some of this. First of all, everybody knows, and I said this at the meeting in Washington, And it was kind of, people were laughing a little because it was a play on words, but it really isn't a play on words, it's reality. You equals you only when you really is you. And you know what that means. That undetectable is untransmissible if you really are undetectable. So that's the responsibility that the individual person has to make sure that they are in fact undetectable. That goes without saying. There's nothing that is disparaging about the concept, it's just a reality. So there are several challenges, and I'm going to quickly go through 4 of these, and they're shown on this slide. 1, the time to viral suppression. And this was manifested by that one case that there was a transmission when the person was on drug for only 4 months. If you look at the first 6 months of antiretroviral therapy, now everybody knows that biology, unlike mathematics and physics, is not a precisely exact science. So you have to look at likelihood of things. And if you look at the first 6 months of antiretroviral therapy, it diminishes in what the relative risk is of there still being virus. So HIV incidence before ART was 2.8 per 100 person years. If you looked at people on ART who had only been on ART for less than 6 years, it went down from 2.08 to 1.79. But if you looked at individuals who'd been on ART for greater than 6 months, again, the risk was 0. That tells us that the residual HIV transmission risk does persist during the first 6 months of ART. So if you're going to incorporate you equals you into your life, make sure you realize that you should be on therapy for 6 months. And this is just a graph that shows that within the first 6 months, you're not, almost certainly 100% of people will not be undetectable. But once you get to 6 months or greater, you get into the you equals you zone. So make sure we get the timing right. The other thing is the importance of regular viral testing. You equals you, that's what I said, only when you really equals you. So if you do a viral load now and do a viral load 3.5 years from now, you're not going to be 100% sure that you're still you. So the CDC and the panel of the guidelines for drugs say you enter someone into care, you start them on ART, you modify the regimen if necessary. 2 to 8 weeks after initiation, you test again, and you do it about every 8 weeks until the viral load is suppressed less than 200, and then you go to every 3 to 4 months, and if you do well over a period of 1 to 2 years, you can do it then every 6 months. Just the bottom line of this, so that you don't have to memorize what's on that slide, it's easy, you can get it in the computer, is that you just don't go in with one viral load and say, I'm done for 5 years. That is not what you want to do. You want to follow it. And that relates to this slide. I get asked all the time, what about blips? Well, let's examine this. In the blue are blips. I see patients every day. I look at viral loads all the time. And every once in a while, for one reason or other, someone will get a little blip, and it'll go right down the next day. But there are also things that look like they're blips, but then they really are rebounds. So if you're getting your viral load testing and you're undetectable, you're fine. But if there's a blip there, make sure you follow up that that blip isn't a rebound, just for your own safety. Because a blip is a blip if you see it once, but if all of a sudden it starts doing that, it's not a blip. Okay, here's another thing that sometimes is confounding. The viral load is negative, but people now with the PCRs that we have, they look in serum, in semen, and vaginal secretions and rectal secretions. Being PCR positive in a body fluid when your plasma viremia is undetectable does not necessarily mean that you have culturable, replication competent virus. Let me explain what I mean, because that could drive you crazy if you go and get a PCR and say, I have this amount of non-culturable PCR positive. Let's look at the data. We're an evidence-based group in this room, so let's look at the data. So if you look at a study that was just published in the JID in 2016, when you look at RNA detection, this is not culturable virus, this is what you're PCRing. 0 to 3 months after ART initiation, there was 24% of the people had detection of PCR. 3 to 6 months, 10% had it. Now remember I told you, greater than 6 months, you're home free. But 11% of people had PCRable nucleotides in their semen at 6 months. What does that mean? With full virological suppression, there were no transmission associated with that. So again, if you're 6 months or greater, and somebody says they want to do a PCR on your semen, and they say, well, you have X number of copies of virus, that doesn't mean it's transmissible. Okay. Adherence challenges. We are all human beings, and we have the foibles of human beings, and we sometimes play around a bit, sometimes carelessly, with medications. Of HIV-positive people in the United States in 2015, 20% were not virally suppressed at their last test. That doesn't mean that they weren't adherent, but they weren't virally suppressed. So remember, you equals you when you really is you. 1/3 of the patients in HIV clinical care did not maintain viral suppression over 12 months. If you stop ART, many years ago, we did an empiric study that asked if somebody had been on therapy for 3 years or more, if we stop therapy, would the virus stay suppressed? Well, you all know that study. That's been published many, many times, this classic study that we published in 1995. Virtually everybody rebounds. So if somebody stops antiretroviral therapy, it is highly likely that within 2 to 4 weeks, they will not be you anymore. So be careful. So this is my last slide, and I want to just recapitulate what I said. U equals you and risk, because whenever you talk about U equals you, people are saying, what kind of risk are you taking on yourself and on your partner? Well, life is full of risks, both big and small. We live with risks every single day. All of us have different levels of risk aversions. But in the last bullet is important. Each of us must weigh the cost-benefit risk of our many activities, hopefully based on evidence base. And I hope that I've convinced you over this 25 minutes that the evidence that U equals you is overwhelming. Thank you.
Hi, thank you. Hi folks, we'll be kicking off the next session in just a second. We just need the obligatory photo. One moment.